Good afternoon, everyone. My name is Randy Schneider, and it's my pleasure to introduce Abbott's next Med Talk for the day. Today's Med Talk is entitled Enhancing Wellness Through Guideline Concordant Follow-Up and Treatment for Patients with Diabetes and Chronic Kidney Disease. It's also my pleasure to introduce our panel. We have here today Elizabeth Montgomery from the National Kidney Foundation and Dr. Chris Koch from Sanford Health. She didn't show me how to use it. Here we go. Some housekeeping, some disclaimers as it relates to today's Med Talk. The speakers are here on behalf of Abbott. This talk's also supported by Abbott. Views and opinions of the speakers today are really specific to the speakers, not necessarily an opinion of Abbott. Also, data from Sanford Health and our use case that you'll hear later about today is specific to Sanford Health. And nothing's really tied to our claims. This talk's a medical talk, but no specific data, conclusions, et cetera, should be tied to our claims. Okay, so the goal for the next 20, 25 minutes is really, hopefully, for you to walk away with a better understanding of chronic kidney disease, opportunities to reduce those associated comorbidities, and hopefully improve outcomes for people with chronic kidney disease in the future. As well as highlight an opportunity for lab professionals, really articulate how those leaders can drive similar outcomes in this patient population at their institutions. So Elizabeth, maybe I'll start with you and I'll ask a very simple question. How big is this problem and where are we in current state today?
So thank you, Randy, for the question. Why don't I take the clicker so we can walk it through. So in the United States today, 1 in 7 adults, about 35 to 37 million Americans, depending on the number that you use, actually have chronic kidney disease. It is a significant population in Medicare. What we see in the data is that in the Medicare population, CKD represents about 15% of the overarching the population, but 25% of the total Medicare spend annually, which is not trivial. It's in excess of $100 billion annually. What we're here to try to change is the fact that in the United States today, 9 out of 10 people with chronic kidney disease with laboratory evidence of chronic kidney disease will not be diagnosed in primary care settings. And that includes as many as 40 people whose kidneys are already in advanced CKD or have already failed. What is so interesting for me is that, and you all know that, right, working in the laboratory world, that because serum creatinine with EGFR is part of a basic or comprehensive metabolic panel, 80% of individuals with chronic kidney disease have diagnostic information in their electronic health record already that for whatever reason is not being recognized or responded to in primary care settings. And so we're working to change that. And we're working to change that by kind of changing the narrative around kidney disease. So the graph here speaks to the distribution of chronic kidney disease by stage. So that's the dark blue bars. The percentage of each stage of CKD that's diagnosed are the orange bars. And so you can see that even in stages 4 and 5 of kidney disease, less than 50% of people actually have a diagnosis and are aware that they have kidney disease. Now, you're probably sitting there and saying to yourself, you have this giant population, it's expensive, it is a dramatic progression. Why is this the case? And a large part of the reason is the pink box, that historically Medicare has paid for end-stage kidney disease. So there's a lot of attention on the end because of the significant expense that is supported by Medicare. And if you speak to primary care clinicians, they will often immediately default from chronic kidney disease into, I'll deal with it when it's problematic, which is when it's symptomatic and advanced and moving in the direction of needing some sort of nephrology care. We're trying to change this narrative because the purple line on this graph explains why you and your institutions should really be taking a look at kidney disease as a quality target. For every one person that advances into end stage, 5 to 6 people will expire of a cardiovascular event upstream, never knowing that chronic kidney disease has contributed to the reason they're having these cardiovascular issues. So we're working to change this narrative from chronic kidney disease and end stage into chronic kidney disease as a risk predictor for cardiovascular events and mortality in upstream populations. How we bring this together and why we are working with the laboratory community is that CKD is a laboratory diagnosis. 2 or 3, depending on how you talk to, tests are currently diagnosed chronic kidney disease. Serum creatinine with eGFR and urine albumin creatinine ratio are the more broadly accepted tests. Cystatin C is increasing in popularity, specifically in certain populations. As I mentioned, 80% of people with undiagnosed CKD are in your laboratory systems. You have that data. You all are the first responders. You have that information already in your systems and in the electronic health record that can be translated. So the National Kidney Foundation has an approach that we work with laboratory professionals to bring into their institution, which essentially looks at the rate of CKD testing, looks at the rate of diagnosis for individuals with laboratory evidence of chronic kidney disease, and then works to help build the business case for a laboratory-driven population health model within the institution. So we have this model. This diagram here is essentially the model that we employed at Sanford Health. It starts with this data analysis and then translates into the NKF working with an institution to translate what the laboratory data is suggesting into a return on investment argument for primary care, population health, informatics, and any other team in the organization that may be resistant to change about why this is a smart investment and what the return can be at 24 and 36 months, not only in terms of better patient outcomes, but in better financial performance for the institution. And so it is essentially a scalable, hands-off approach. We come in and help facilitate the conversations so that the institution itself then can take the model, tweak it to what works for their institution, their culture, and their population, and then ideally work together to advance launching that in primary care. So that's essentially our part of the what, the why, and the how. So I'm going to turn this over now to Dr. Koch to speak to the story at Sanford Health.
Yeah, thank you. So we utilized this change packet from the National Kidney Foundation. So we did benchmarking. We took a look at our data, and everything that you said was present at Sanford. So we were not getting testing to all the patients that needed to get testing. When they were having testing, we have a significant population, upwards of half of our population, that wasn't being diagnosed in the chart. And then we also didn't see great follow-up with patients that were diagnosed with chronic kidney disease in treatment. We now have some great treatments to prevent the progression of CKD and reduce the risk for cardiovascular disease. So started working with our PsyOps team to pull data. Data very clearly show there is an issue here. The business case, super easy, very established that identifying, treating these patients early leads to better financial outcomes as well. These patients are very expensive as they move to later stages of chronic kidney disease and into renal failure. So identifying these patients early there's a very strong financial case for that as well. So we have both the clinical and the financial side of this. So easy sell for us. What I'm more interested in, of course, is the impact to patients. So we chose within this framework to focus on 3 different things. Okay, so closing the gap in access or utilization of the urine creatinine albumin ratio testing. Once the patient has that testing, to have the providers actually diagnose the patient, to get those ICD-10 codes in the chart so we can properly follow up with those patients, and then focus on the intervention. So once they are diagnosed, giving them proper medications, again, to slow the progression of CKD and reduce that cardiovascular risk. So this is kind of a busy slide. This is how we actually approach this. So on the left side of your screen, we developed a Sanford-specific algorithm that is consistent with the National Kidney Foundation guidelines and other organization guidelines for best practices. I realize that's small, not intended to read. We also, a big thing is making it easy for providers to order. And so this is really where the laboratory got involved with this, is we implemented what's it called? Help me out.
Best practice alerts.
The best practice alerts, but the
and
testing.
The UACR, EGFR.
Yep. So the kidney profile.
With the kidney profile.
There we go. The kidney profile test, which includes the serum creatinine with EGFR and then the urine albumin creatinine ratio. So we have a chemistry work group that we set up a pipeline. We have a long-standing pipeline for any test requests. Those test requests came to us with evidence of how it's going to be used clinically, so it's an easy approval for our work group. So that's being used within the enterprise right now. Other things that we did for ease of ordering, we developed nursing protocols, the disease-specific protocols that allow nursing to order based on the disease. So the providers don't necessarily have to think about this anymore. It's sort of we're crowdsourcing the ability to test these patients. So we have the nursing protocols. We put in best practice alerts into our EMR. We use Epic, not any. So there's maybe some terminology here. I'm not quite sure, but our practice alerts, I think, if you're an Epic user, is what we use. We did a couple things with best practice alerts. If a patient had an ICD-10 code for diabetes and they did not have guideline-appropriate testing at the frequency that's recommended, they would get a best practice alert to provide that testing. If they also had evidence of both diabetes and potentially kidney disease and weren't on medications. So blood pressure lowering medications like ACE and ARB inhibitors, or if they were diabetic, the sodium glucose transporter 2 inhibitors as well. So they get those alerts. And if they don't have any labs, they would also get those alerts prompting that ordering of appropriate testing. We also created CKD screen and treat smart sets in the EMR. And so this would give providers prompts for proper prescribing based on the laboratory results and the other findings of that patient, including the ordering of CKD labs, which now also includes the urine creatinine, albumin creatinine ratio. And then education was a big piece too. So we didn't just roll this out and expect our providers to just do this and know what was going on. We held webinars, several webinars in December of 2023 before we rolled this out to educate our providers, to talk not only about what we're doing here, but also the associated cardiovascular risk with chronic kidney disease, diabetes, and hypertension. And then also with patients. And so we implemented a suite of educational materials within our EMR for easy access that our providers could provide to patients on what it means to be diagnosed with chronic kidney disease, how they can manage their own care, medications to avoid, because our goal here is to diagnose earlier. And a lot of times these patients are asymptomatic, and so we really need to impress on patients the importance of the fact that this is a progressive disease, and there are steps that they can take to help that, to slow that progression. So we have some pretty profound data after we implemented this. So I'll turn and point here. So looking at the ordering of the urine albumin creatinine ratio, pre-2024, or aggregate, sorry, pre-2023, we had approximately 40% of patients who are receiving guideline-appropriate testing. You can see how this has dramatically increased in quarter 1, 2, and 3 after implementation. And as of Q3 2024, we have more data. We're still going through that data, but the last data review, we're up to 70%. So again, we went from 40 to 70% with just these simple implementations. As far as when a patient does get tested and has evidence of CKD, laboratory evidence, we saw very little follow-up by providers by actually assigning the ICD-10 code. And so we started at 20%. Similarly, we're now at 73% of patients that have that appropriate ICD-10 code. And then looking at actual treatment, so focusing on diabetic patients with CKD diagnosis, are they being treated? And so we can see the sodium glucose transport 2 inhibitor prescriptions. We started out at a very low percentage, it was at 2%. I think we're up around 10% of patients now. So very, very exciting data for us. We are excited to see where this goes. We're still collecting data. And I'm curious, in your opinion, what would it take for us to get to 100%? I'd love to see that we're at 70%, but where can we go from here? What additional things can we do?
I appreciate the question. So specifically, the rate limiting test in this conversation is urine albumin creatinine ratio. And so what we hear is that part of the reason that there are breakdowns in the testing are patient-related. That patients, when they go to the lab, they aren't aware they need to give a urine sample. And so because they think they're going to be waiting, they may have used the bathroom before they actually go into sample collection. So thinking that through in terms of if you're doing nursing protocols or community health worker outreach to remind people that there is an appointment coming, they need lab work done, to remind them that it will be blood and urine. I'm a giant fan of having bottled water in the reception area. I don't know how operationally possible that is, but I see that. We're working with the VA right now, and I'm like, just put the water bottles there, because by the time they finish their clinical encounter and you're sending them to the lab, they're going to need to have, to use the restroom. So let's find a creative way to get around that issue. We also encounter in some situations that there's confusion around the laboratory results that come back as unable to calculate. That many primary care clinicians may not have a clear understanding of how to interpret that. So helping to ensure that there's nothing on the laboratory side that prevents that testing from being recognized as having occurred is really important. And then having a conversation with the primary care clinician to let them know that unable to calculate in this test is actually a really good thing and indicates that there's no kidney damage.
Okay.
So those are our two kind of initial pieces. The third thing I would suggest, and again, this goes back to your comment about educating patients. 9 out of 10 people with kidney disease do not know they have it. That's a CDC statistic. So any opportunity you can take to help them understand that chronic kidney disease is evident and that it's something they should be thinking about is going to be really helpful in us ensuring that they take this seriously and that they understand that there's opportunities or things that they can do to actually begin to drive change. So potentially working, if you're in an academic center, large integrated health system, working with the NKF to promote awareness around kidney disease to your patients during Kidney Month in March, so that people are provided with ongoing information that they need an annual test if they're at risk with diabetes and/or hypertension. And there's a reason they really want to be thinking about this because of its dramatic impact on their overarching health. Is that helpful?
Absolutely, yes. Yeah, the interesting comment. Your first comment about basically our phlebotomy areas. Starting there, I haven't thought about that before, and yeah, I think that's we're at a lab conference. We always talk about the value of the lab, and I think that it's an excellent point that they are part of the lab too, and preparing the patients, making sure they understand that they have to give a urine sample. Ideally, it would happen before they arrive, so they're prepared, but also then having that staff being able to facilitate that collection, work with the patients on site is an excellent point, and one that I think we could potentially address to help this.
That would be amazing, because that additional mile is a challenge.
Right.
And so anything you can do to get there. Another consideration, and again, if you're in an academic lab, is to try to shift people away from trying to do a dipstick in primary care, because that also plays into some of the attrition and performance. When you think about the value, and you're all in the lab, right? So you know the value of laboratory testing. But in this specific case, we want quantitative data, not qualitative data. And so if primary care are running dipsticks, that data is not going to translate into fulfilling the kidney health evaluation HEDIS measure, which is associated with this testing. And it's not going to easily translate into recognition of CKD and diagnosis. So kind of working to recondition the clinical teams to think that we really need to do this quantitatively as opposed to semi-qualitatively would be important.
And additionally, with the point-of-care dipstick methods, you're typically not getting a urine creatinine as well.
Correct.
Is that correct?
That's
so you're
exactly
just getting
correct.
albumin, and you really need that ratio to be able to help diagnose.
Yeah, 100%.
Yeah.
Chris, if I may, a question around the timing of how long it took for this program to be implemented, maybe just some characteristics about your healthcare system specifically that may translate to others that have rural, city scope within the system.
Well, can I answer part of that first?
Sure.
Right.
Go for it.
Their team was amazing. That is all I want to say. That I think everyone at Sanford Health was shocked when the data came back and said there was such a low level of urine albumin creatinine ratio, and it started a fire drill. And it was a response. We work with a lot of institutions nationally. It was a unique response in that we want to fix this because we want to be, proud of who we are and the type of care that we provide. And so there was a full-blown response within the institution of bringing in senior leadership and helping orchestrate the nature of the conversations that we needed to have so that the aircraft carrier would turn rapidly. And so that's just why I want to say you guys are amazing.
Thank you. That's great to hear. Very, very proud of our institution for having that sort of response. And as you mentioned, turning the aircraft carrier, that is absolutely true at Sanford Health. We are a very large IDN we have a footprint of over 9 states now. And so yeah, sometimes it's difficult to get things done. And the fact that we could turn the ship, and see the data, turn the ship, everyone's on board. I think that's a testament to the framework that the National Kidney Foundation has developed, that it can take a large institution where it is historically very difficult to make change quickly and do just the opposite and make that change. And so I think looking at your change packet, I do think it's a lot of things that us as laboratorians have tried to do for years, and we do it piecemeal. Right. And a lot of times it's challenging to get to the higher level people that actually can start to help us make some change and decision. I think with this framework out there, it's, as you mentioned, it's scalable. And it gives us that framework, not only for the laboratory to initiate these changes, but actually in this situation, the laboratory didn't initiate the change. It was dialysis, involved with laboratory. So I think it's great that we have that framework out there now. I think it can be applied not only to chronic kidney disease, but to other areas as well. I'm starting to think about all kinds of other areas where I can apply this to and make some real meaningful data-driven change as well.
So maybe to that end, Elizabeth, I'll give you maybe the final word on the call to action here, right? It seems like, and maybe a data point, share a data point with the audience. This worked at Sanford. What's the opportunity still, right? I mean, 50% of hospitals are doing this, 20% of hospitals are doing this. I'm being sarcastic, but what's the opportunity?
The opportunity is huge. While I'm happy to say that the NKF is working with 50 organizations in this capacity, there are literally hundreds, if not thousands more that we need to engage in a conversation here. And again, you think about, typically during a presentation like this, I know I'm in a laboratory community, but I would ask the question, how many of you know what your current EGFR is? Anybody want to raise their hand? Anybody know what your current EGFR is? So how would you feel? We have a board member, captain of industry, runs an organization, 800 employees, Ivy League educated. He was under the care of a primary care clinician for 12 years, going twice a year, because he knew his family had a history of diabetes and hypertension. Going to primary care twice annually to get a follow-up test. His primary care clinician retired, and the new doctor met him at the door at the first appointment after the retirement of the colleague and said, you need to go to the ER right now. You are in kidney failure. It's asymptomatic. You don't see it. You don't feel it. No one in this audience knows their EGFR. What would your life look like tomorrow if you were told that you either have to find someone who's willing to donate a kidney or you're going to live on transplant for the potential 5 years remaining in your life? Our outcomes are worse than breast cancer, colon cancer combined. How would you feel?
Yeah.
And how willing are you to consider how to translate that into the impact on the patients that you all support? Because we can prevent all of this. This is a preventable disease. The SGLT2 inhibitors that Dr. Koch mentioned, that there's data that was published recently that can avert end-stage kidney disease for 13 years. So think about the impact that kind of information, that kind of treatment can have on someone who's just been told that they have a life-threatening illness and be given the opportunity to do something about it. So I'd like to say it's a moral obligation for us to kind of step in, given the significant size of the population and the relative financial impact that this can have on all of our institutions. Because if your institution isn't a value-based model, this is flying underneath the radar and undermining performance. And it's driven by ER visits, hospitalizations, and readmissions that look like cardiovascular disease. We've done a study with CareFirst, large Blue Cross Blue Shield payer in the Mid-Atlantic, where at 24 months there was a significant reduction in ER visits, hospitalizations, and readmissions, just because we got people tested and diagnosed. So there's lots of opportunity to really drive change, have a tremendous impact. Kidney disease disproportionately affects communities of color, individuals who are struggling with socioeconomic achievement, educational attainment, food insecurity. There's lots of opportunity to not only do what's good for the organization, but do what's good for the community and the people that we all support. But you got to call us first and or go to our change package on the website, which is free to everyone. You can download it. It literally will walk you through the process steps. I'd like to suggest that what Dr. Koch said about having the National Kidney Foundation help you translate this is helpful, because we're speaking to institutions all the time. So if you have an interest in doing this, let us know. We'd love to have a conversation about how we can help you facilitate this. And even if the only thing you do is ensure that ordering the 2 tests is easier, that will make a tremendous impact over time, because one of the greatest rate-limiting factors is people don't know what microalbumin means, and they don't necessarily translate it into kidney disease, so the test doesn't always get done. So implementing the kidney profile can help with that.
Thanks, Elizabeth. So we have time for a couple questions, perhaps. So I would open it up to the audience, and there will be a microphone passed around here. Oh yeah, we have to put these on. Yeah. And the microphone's here. Questions? Okay. Okay. Well, then I would also encourage you to come up and talk to Dr. Koch about his experience at Sanford, as well as Elizabeth. If you're interested in partnering with the National Kidney Foundation. I would also encourage you, if you like this Med Talk, there will be more of them throughout ADLM, so please come back and visit us here at this booth. We'll cover other medically important topics, and appreciate your attention. Thank you.
Thanks, everybody.
Nice job, you two.
Thank you.
Good job, yeah.